Sorry for the complications, everybody. We're going to start the webinar right now. So welcome to our 2016 webinar on plan certification. I'm Nick Proper with the Exchange, and we have Glenn Shippey here from the Division of Insurance, and our contractor Heather Seiden presenting as well. Heather is contracted through our project management office, and some of you may know her from last year as she was involved in carrier onboarding, and this year she is assisting the Exchange with the transfer of plan certification duties from the DOI. Here are a few notes about Nevada. Nevada is one of 3 states currently using this model. And for on-exchange plans, they're going to be certified by the Exchange. And Healthcare.gov is the web portal used for display and enrollment. Application in the form of a CERF binder is required by 513. And I want to emphasize, and this is per a direct response from SOCIO, that incomplete or partial binders and templates will not be accepted and cannot be transferred to HIOS or CMS. So please make sure the templates are complete. Also, the Unified Rate Review template must also be submitted in HIOS as well as CERF as a supporting document. Here is the QHP certification timeline. Again, 513 is when binders are due in CERF, and 515 will be the first CERF data transfer to CMS. And 615 is when correction notices will be sent to the carriers via CERF. Here are the required templates for QHPs, and please make sure to use the latest versions of each. And keep in mind there's a separate section later about the template requirements for dental plans, as they don't use all of these required QHP templates. There were some changes to the benefits package worksheet within the plans and benefits template, which some of you may already know at this point. The fields EHB, percent of total premium, and does this plan offer composite rating were added. And child-only plan ID is not required for catastrophic plans. Weight loss programs was also an option added under disease management. And keep this in mind, it's very important that the plan effective date must be 1/1/16. There were also some changes to the cost share variances worksheet in the plans and benefits template. 2 fields and some URLs were just moved from the benefits package worksheet to this worksheet. The SBC scenario fields are required, and family fields for MOOP and deductible require per person amount or NA. In the plans and benefits template, we recommend selecting yes for unique plan design only if it is difficult to duplicate the template AV with the standalone calculator. The fields is a referral required for specialists, and specialists requiring a referral are required, and the field disease management programs offered is required if programs are offered. Also, the EHB percent of premium must match the value in the Unified Rate Review template, and the percentage could be greater than 100 if the benefits are greater than the minimum. Also, the URLs are required as well. In the business rules template, the required minimum relationships need to be spouse, adopted child, foster child, ward, which is a disabled dependent, stepson, stepdaughter, self, child, life partner, and other relationship. Now I'm going to hand off this part of the presentation to Heather so she can go over some application tips and hints.
Good morning, everyone. And again, sorry for the complications, and please pass along to your teammates who may not be on this presentation that it will be recorded and available on several websites. So here, whoops, our first template, the plans and benefits template, you should make sure that you have each product in its own benefit package in the template. You must select the QHP and non-QHP because of the guaranteed availability. And also for specialties, if there is a yes in specialty and specialist requiring a referral, the next field has to also be populated. And most of the time you're going to populate that with all. And the individual plan, the expiration date is always going to be 12/31/2016. And this isn't applicable to SHOP because SHOP you can enroll at different times of the year. And then the payment URL. Last year we had some issues with the payment URL not working. I think a lot of the carriers will remember that. So we are going to be extra diligent about testing that payment URL this year. And you want to be sure that you have that the correct URL. And the URL has to be going directly to the payment page. It should not just go to your website. So some additional plans and benefits template tips. There's some things here you can verify. The deductible does not increase as actuarial values increase. There's some other cost sharing tips here. I'm going to go ahead and let you read these ones over. These are some specific tips for plan and benefits template. So accreditation, there's 3 different accreditations that you're going to be able to use, and each one of those has a separate template. So just be sure to use the template that applies for you. The Indian Healthcare Providers Addendum, what this is if you contract with an Indian provider, you need to sign an addendum that contains additional terms and conditions that apply specifically to Indian providers. And there is a form, and we've attached it in our email. There is a form you can use. You're not required to use that specific form. It's called the Model QHP Addendum for Indian Healthcare Providers, but that does contain the terms, and for contractual purposes, that's probably the best form to use. And those terms will supersede any terms in the regular QHP network provider contract. The administrative template, you need to be sure that you enter your administrative information into HIOS as well as into the administrative template, because the HIOS data is what is used to populate Healthcare.gov. Unified rate review, you're going to verify your list of plan IDs entered on the URRT template and the plan and benefits template, and those should match exactly. And I believe that SADPs do not have to do a URRT. Essential community providers, this is just making sure that you have the number of providers within your community. And if you're entering in an ECP with multiple locations with the same provider name, you want to add 3-digit numbers for each location. So for example, provider and then put 001. And write-ins don't need to include individual providers if they share the same group or company address. You can just list the group. And you're required to do the ECP supplemental response form if you're not meeting the specific requirements. The plan crosswalk, there's actually a tool for this as well this year. So you're going to include all plans that were offered on the marketplace in 2015, including those that were suppressed following open enrollment if they did get enrollees. You don't need to include withdrawals on this. And you're going to want to keep the file name that's created. It's going to create an XML file. And all that information is contained in the instructions on CMS, the information on how to create your XML file. And then when you're entering the reason for crosswalk, only select discontinuing product if you're not offering any plans in that product in any counties for the 2018 plan year. I'm going to jump ahead to this Plan ID crosswalk template since we were just talking about Plan ID. But that template, the XML formatted information, has to be sent to QHP applications at cmshhs.gov in addition to being uploaded into SIR. So be sure that you have that as a to-do for your Plan ID crosswalk template. So this slide contains some additional supporting documentation. Again, the ECP supplemental response form, if you are required to do that, the statement of detailed attestation responses, the formulary, drug formulary information, the URR template, and then the accreditation template. Oops. So this is just some information on the QHP benefit standards and product offerings. You're required to offer 1 silver and 1 gold plan in each carrier service area, and they can be offered with or without embedded pediatric dental. And you can offer a maximum of 5 plans per metal tier within a service area, and that does not include the cost sharing or Medicaid transition plans. And you're only required to submit a 0 cost share variation at the lowest metallic level for each product. For the service areas, the service area rating territories are the same as last year. And QHP and SADP service areas must equal 1 or more rating territories. And you can't use any partial counties unless you are off exchange. So I think most people on this call are doing on exchange, so keep in mind no partial counties. And I'm going to turn the next slides over to Glenn Chicken from the DOI.
Well, thanks, Heather. We welcome everybody that's on the call, and I want to just make a few comments before I get started on my portion of the slides, in that this is a transition year for plan certification. We are transitioning a lot of the responsibilities from the DOI over to the exchange, but for this year, we're going to be working in partnership, the DOI with the exchange. You'll see very little difference this summer versus what you experienced last year and the year before. The process is nearly identical. I'll be closely involved and will physically be over at the exchange several days a week throughout the summer. And we're here, myself and Nick and also Heather to, we want to be accessible to you if you're having any issues anywhere along the way, whether it's prior to submission or post-submission. If you have any questions, please reach out to myself or Nick or Heather, and we'll be happy to assist you. So network adequacy for QHPs is the same process that the DOI is going to be using for all plans in each market segment. I just want to make it clear to carriers for QHPs that network adequacy support is not to be included in the QHP binder. There is a separate network adequacy binder that is going to be submitted by a carrier, and it's going to be a single network adequacy binder for both the individual and small group markets and all plans in those markets. So there won't be a QHP network adequacy binder or an individual market network adequacy binder or any network adequacy support in the QHP binder. So just want to make sure that you understand the process for network adequacy for QHPs is identical to the process for non-QHPs in both the individual and small group markets. One of the certification standards, and this is going to be mostly the responsibility of the DOI, is meaningfully different plan designs. And this isn't new. What makes one plan meaningfully different from another plan? Well, it has to be different in either metal level, service area, plan type, premium and cost share, provider network, covered benefits, or formulary structure. There is a CMS tool that the DOI and exchange will be using to determine meaningfully different plans and identify redundant plan offerings. And like all these tools that CMS has released, we strongly encourage that carriers use these tools on their own templates prior to submission. Don't wait for the DOI or the exchange to identify issues. If you utilize these tools prior to submission, then you can make changes and make this process much more efficient down the road. The next slide on discriminatory benefit design. This slide was exposed in a DOI webinar last month, and there's some areas of emphasis that is exposed in the 2016 payment notice, and we will be adopting these areas of emphasis as part of our review of QHPs and non-QHPs, and this will be mostly a DOI responsibility. I'm going to move on to rating and premium standards. And as we all know, the rates for a QHP on the exchange must be identical to the rates for that plan off the exchange. The single rating requirements are applicable across the market, whether the plan is a QHP or not. For the shop, rates must be set for an entire benefit year, although in the small group market, carriers are free to make changes on a quarterly basis. Individual carriers don't have that flexibility. For shop plans, we will need, if a carrier wants to revise rates in a middle of the calendar year to be effective either the second, third, or fourth quarter, we need that rate filing at the DOI at least 4 months prior to the effective date of that rate change. That is to allow us enough time to review and approve revised rates and also be ready to upload those revised rates to the federal hub so the revised rates can be displayed on Healthcare.gov to be effective the first day of that quarter. As you all know, the segregation of funds is required, so carriers must segregate funds allocable to APTC, to the individual, and also funds cannot be used for elective abortions. Currently, in the 2015 QHP segment of the market, no carrier provides coverage for elective abortions, so that's not an issue. I don't anticipate that to change in 2016, but if there is a carrier that's intending to provide coverage for elective abortions, then that needs to be, those funds need to be segregated. You cannot use federal funds for that purpose. Now I'm going to move on to the certification process for standalone dental plans for 2016. And this really hasn't changed significantly. This was the same process. For those carriers that are coming back for 16 that are currently out there for 2015, the process is nearly identical. As was pointed out earlier by Nick, the submission deadline is 5/13. That's applicable to standalone dental plans on the exchange, also off the exchange. We do have a number of dental carriers that only sell off the exchange. This process is the same for the off-exchange dental carriers as well, with some exceptions. One of those exceptions, of course, is with a CMS Plan ID Crosswalk template. That is not applicable to the off-exchange standalone dental carriers, but the on-exchange standalone dental carriers will need to submit that CMS Plan ID Crosswalk template. Dental carriers will not submit applications in the HIOS. Attestations and other supporting documentation in general will be collected after the final data transfer in August. And as with QHP carriers, there will be a CMS issuer agreement that will need to be executed down the road. There are many certification standards that are applicable to QHPs, but not the standalone dental plans. They're listed in this slide, and that's similar to what existed last year. The timeline for standalone dental process is very similar for QHPs. Nick went over that earlier, so I won't repeat that, and I'll just move on to the binder requirements. The validated templates that need to be included in standalone dental binders for carriers both on and off the exchange are the plans and benefits template, the rates table template, business rules template, service area template, network template, ECP template, and administrative data template. All of them have to be validated, and in supporting documentation, we will need at the time of submission for on-exchange standalone dental binders, as I mentioned before, the CMS Plan ID Crosswalk template. The plans and benefits template really hasn't changed for dental carriers from the one that you used last year. There's not a lot of detail in the plans and benefits template for standalone dental. There are only 4 very broad benefit categories for pediatric dental benefits. There's dental checkup for children, basic dental care for children, orthodontia, and major care for children. We do not want carriers to add any additional benefit rows. So you'll have to work with those already built in broad dental categories. For those family plans that have adults benefits, then go ahead and mark those broad categories as covered. But do not, accidental dental is a benefit row that's included, but does not have to be covered. I don't think any of our carriers are covering that. If you choose to cover that as an optional benefit, then you could indicate covered for that benefit as well. As I mentioned, these are very broad categories. So what we want to see in populating the quantitative limits for those broad categories, we want you to populate the highest utilized benefit within that broad category. All the other details and limits for those other benefits in the broad category will be in the plan docs. We also want some of those limits to be incorporated into the benefit explanation field. That is a field that's available on Healthcare.gov for display to a consumer if they choose to look at it. So that's an opportunity for you as a carrier and for us to get some additional information that the template doesn't explicitly capture about those other benefits that consumers are typically interested in. The plan brochure is also something that's important that is displayed to consumers. And I'm going to go ahead and go to the next slide to give you a little peek at Healthcare.gov. We don't expect Healthcare.gov to change very much in what it's going to display in terms of dental. Consumers are just going to see those broad categories that you can see on the slide here. I want to emphasize that the URLs have to be, you'll need to submit URLs in the initial application due next month, but they have to be working URLs no later than August 15th, because when we transfer the final data no later than August 25th, those have to be working URLs. So we're going to verify that those are working by August 15th. The EHP allocation for pediatric dental, what's important here, and this isn't a change, that EHB allocation cannot exceed the premium for the child-only plan. We discussed that over the past several years, and I know there's been some confusion around that, some of it generated by the DOI, and I'm going to touch upon that later on. As we required last year, a description of EHB allocation form needs to be signed by an actuary and submitted, and that will be a part of the rate filing and that binder. Unlike the individual and shop QHPs, standalone dental has some flexibility in rating, and if a standalone dental carrier, and let me talk about, and this is going to the next slide a little, let me talk about that rates table template. That rates table template is designed for QHPs. However, it's the only template available to us to collect standalone dental rates. So we're kind of bound by the restrictions of that template, and what that means is primarily with the age categories for QHPs in that first age band, which is 0 to 20, which is the first age band for health benefit plans, including QHPs. Standalone dental plans don't have the flexibility on that template. They have separate rates for 19 and 20-year-olds. 19 and 20-year-olds do not use pediatric dental services. So there is an option for carriers, and this option is on the business rules template, to go ahead and say that you're going to use estimated rates rather than guaranteed rates. Selecting that option of estimated rates allows dental carriers to have different rates for 19 and 20-year-olds. It also gives you some flexibility, and I'm going to move forward to the business rules template slide. It also allows flexibility to, let's say, charge for more than 3 children on the plan. So there's flexibility there. On the business rules template, that set of relationships between primary and dependent that Nick went through, that same set has to be selected at a minimum for standalone dental plans, and that's applicable to on exchange, right? Off exchange only dental carriers don't need to worry about those relationships, because this is, and let me talk about that a little bit and identify one of these relationships. The reason we're requiring board is to allow older dependents, disabled dependents to be covered, which is a mandate under Title 57 and better revised statutes. I'm going to move to the next slide. There are different board decisions that were made relevant to standalone dental plans. Some of these board decisions that were made several years ago are not supported by Healthcare.gov. One of those decisions is that any individual that shops on Healthcare.gov or on the exchange for a plan, if there's a child in the household, the board requires that it's a mandatory purchase of standalone dental if there's not an embedded plan that's chosen. However, that's not supported by Healthcare.gov. I just wanted to point that out. That was pointed out last year, too, at some point. A big change on the shop is that employers may purchase standalone dental without purchasing a QHP. So that's a big change. That change has not been made for the individual exchange, however. The form filing guidance, this was exposed during the DOI webinar last month. So this isn't new information for those that looked at that presentation. What's important here is that we get this question every year. All forms need to be resubmitted annually for either recertification or reapproval, even if there aren't any changes to those forms. We need to revisit those forms If there are any changes, then we'll need a redline version of all forms to identify what those changes are that are being proposed. The two types of forms that we require, the schedule of benefits and also an evidence of coverage. All the covered pediatric dental benefits do not have to be included in the schedule of benefits. You can have just the major benefits that consumers tend to refer to in the schedule of benefits. That's really a summary. However, the evidence of coverage does need to include all of the covered pediatric dental services. If you're not sure what that set of D codes is that's required, we do have that posted on the Division of Insurance website. And I think that's more for any new dental carriers that may be interested in selling certified dental plans. If you haven't seen that benchmark plan that was chosen, it's the CHIP plan that was in existence in 2012. It's not the federal plan that was an option back then. Uniform modification rules do not apply to standalone dental plans. So dental carriers have a lot more flexibility than the medical carriers have. You could use the same set of HIOS plan IDs for 2016 that you're using in 2015, regardless of how different those plans may be. But since there haven't been a lot of changes to rules around standalone dental plans, you're probably not going to make major changes. But if you want to change the cost share structure of any of your plans, you're free to come back with the same HIOS plan ID. If you do make changes, just keep in mind that the 60-day notice of renewal of all the terms requirement is applicable to dental as well. That's a Nevada-specific requirement. Annual limits on cost share haven't changed. It's still $350 for one child, $700 for two or more children. And only pediatric dental benefits are subject to the EHB rules. So the family plan with adult dental, the adult dental benefits are not bound by these EHB rules. So you have flexibility. You can have a different out-of-pocket and so on with the adult benefits in a family plan. As I mentioned before, the set of pediatric dental essential health benefits are on the DOI website. We provided a link here on this slide to make it easy for you to refer to that set. All those D codes, relevant D codes that were covered by CHIP, back in March of 2012, have to be covered by every certified standalone dental plan in the individual and small group market. The only essential health benefit that allows a waiting period is orthodontia at this point. We have identified that in this benefit, we've identified several carriers that had waiting periods in excess of 12 months. Most of the market, except for a couple of carriers, either didn't have a waiting period or were at 12 months. So those carriers that are at 24 months in 2015 need to change their plan designs, and we're not going to approve and certify any plans that are proposing a waiting period for orthodontia in excess of 12 months. If you're wondering what the statutory authority is for that, it's federal. It's discriminatory benefit design. We've identified this as an outlier in the market, and discriminatory benefit design does not allow any plan design that will tend to discourage certain individuals from purchasing that plan. And we believe that a waiting period of 24 months would be a discriminatory benefit design. I'm going to move on to the rate slide. And we have Nevada statutory standards around dental. Those Rating standards and criteria are in Chapter 686B of NRS. Rates must not be excessive, inadequate, or unfairly discriminatory. Those standards are also applicable to medical plans. What's unique, though, to dental plans is we do have a loss ratio that limits, a loss ratio standard. It limits the expected expense ratio to 25% for individual standalone dental rates. So those plans cannot have a expense ratio in excess of 25%. That's presumed to be excessive. If you're proposing an expense ratio in excess of 25%, you're going to get a disapproval letter from the DOI and an explanation. You're going to have to provide a lot of support for us to consider approving that expense ratio. I want to focus on the last bullet points on this slide, and that is for those family plans that include adults benefits. When coming up with rates by age for those family plans, you need to treat this plan as one benefit package. We've had some issues with carriers that want to treat these family plans as two distinct benefit packages, and those carriers wanted to rate them along those lines. What carriers proposed to us for 2014 and also again in 2015 was to, for an adult rate, to zero out the utilization for pediatric dental benefits. We're not going to allow that. This needs to be rated as a single benefit package. And if you have any questions on that, and if you would like to discuss that, please call me, send me an email. I'd be happy to explain that to any of the pricing actuaries that are looking at rating these family plans. Actuarial value for standalone dental has not changed from the last 2 years. There's a high plan and a low plan, and with a de minimis range of 2%. The support for AV needs to be included in the rate filing, and there's a certification that's required by the actuary. I'll emphasize again, and you all know that the standalone AV calculator that CMS developed is not applicable to standalone dental plans. The last slide I'm going to cover today is on standalone dental off the exchange for the carriers that we have that are selling off the exchange. The reason there is a market for standalone dental off the exchange is that medical carriers are allowed to sell plans without embedded standalone dental if they're reasonably assured that the applicant has purchased certified standalone dental. So only the off-exchange standalone dental plans that are certified, or on-exchange plans that are certified by the exchange for 2016, satisfy reasonable assurance. For those medical carriers that are going to be renewing 2015 plans in 2016 that don't have embedded pediatric dental, they have to obtain that reasonable assurance upon renewal. So that there's a lot of confusion in our marketplace off the exchange regarding what type of standalone dental plan satisfies reasonable assurance. That list of on and off exchange standalone dental plans that are certified is on the DOI website. We're trying to get that guidance out to our broker community so they understand they have to come to the DOI website to see, and carriers that are selling medical plans that aren't embedded need to go to the DOI website to see which plans have been certified. And at this point, I'm going to stop and turn it over to Nick.
Thanks, Glenn. For network adequacy among standalone dental plans, the counties must have at least one general dentist, one periodontist, an oral surgeon, and an orthodontist. And all providers must be within the specific travel standards that I will go into on the next slide. For Carson City, Clark, and Washoe, the maximum travel distance and time is 45 miles or minutes. And in Douglas, Lyon, and Story, it is 60 miles or minutes. And in the rest of the counties, it is 100 miles or 2 hours. Standalone dental plan issuers need to meet the minimum 30% ECP standard, as well as the requirement to offer contracts in good faith to all available Indian healthcare providers in the service area, or submit the supplemental ECP response form describing why those are unable to be met. Also, per the issuer letter, standalone dental plans are not required to offer contracts to at least one ECP in each ECP category in each county, as several providers do not generally provide dental. Therefore, CMS considers that requirement not applicable to standalone dental plans. Now Heather is going to go over some of the tools that should be used for review of the templates before being submitted.
Thanks, Nick. First of all, I just wanted to make sure everyone had the link in which they could download the toolkit, and that link is here on the slide. And this first slide basically talks about the list of tools. There are some new tools this year. I'm going to just briefly touch upon each slide, each tool, and talk about some of the updates for 2016 or whether it's a new tool. So the data integrity tool, what that does is it identifies critical data errors within and across templates. So for 2016, it reduces the number of checks and cross-checks, and it focuses on critical data errors that exclude plans from consumer display incorrect plan information to consumers, or are out of legal or regulatory compliance, such as market-wide requirements. I did forget to mention, the tools are highly recommended. It's not a requirement, but it is a really good way to ensure that your templates are clean when you're submitting, or as clean as they can possibly be. So it really is a great idea to use them. So continuing on the tools, the Plan ID Crosswalk tool, this is a new tool for 2016, and it just basically checks to be sure that your Plan ID Crosswalk template has been completed accurately. It checks for compliance with the CFRs that apply to plans, and it also reviews the template for consistency with submitted service area and plans and benefit template data for 2015 and 2016. The Master Review tool, this is a tool that generates data input files for other tools, and the update for that tool is it's going to accommodate 2016 data. The Essential Community Provider ECP tool, it calculates the total number of ECPs an issuer has in each plan's network and compares this to the number of available ECPs in that service area. And so basically this checks to be sure that your ECP percentage is equal or greater than the threshold defined by the ACA, which I believe is the 30%. And so this is really where you're going to find out whether or not you need to do the supplemental response. If you don't meet the required ECP percentages, then the template should tell you that, and then you'll have to do the supplemental response. And so, so for 2016, the tool has been updated to accommodate 2016 data, and it also compares an issuer's networked ECPs to the non-exhaustive CMS list of ECPs to identify potential write-in ECPs. And if anybody needs that to find out where that list is, it's on CMS, and you can send me a message. I'll send you a link to that privately. The meaningful, let's go to the next slide here. The SADP Essential Community Providers tool is the same thing, but it's specifically for ECPs. I'm sorry, SADPs. The Meaningful Difference tool, that compares plans an issuer offers to check whether there are multiple plans in the same county that would appear virtually identical to a consumer. And that basically makes it easy for you. You don't have to go through and compare the plans yourself. I think it's a good way to identify the differences. And so this tool, the update is that it accommodates new 2016 data, and it compares drug MOOPs deductibles for meaningful difference. The non-discrimination tool, that tool looks at the plans, all plans within the state, and it goes through a group of predetermined benefits and determines if any plan has a significantly higher copay or coinsurance for those benefits, which could potentially mean that the coverage is discriminatory. So this also accommodates the new 2016 data. And it reviews new benefits of inpatient physician and surgical services and durable medical equipment. The cost sharing tool, this is, it runs 3 different checks when they're applicable to the plan for cost sharing standards. This includes the out-of-pocket maximum review, cost sharing review, plan variation review, and catastrophic plan review. And so, again, accommodates the new 2016 data, and it includes review of new per-person family, maximum out-of-pocket, and deductible fields. The category class drug tool, this compares the count of unique chemically distinct drugs in each category and class for each drug list against the benchmark. And the update is simply that it accommodates new 2016 data. The non-discrimination formulary outlier tool, what this does is it looks at plans where there's a high number of drugs that are subject to prior authorization, and it flags them as outliers. These are specific to certain drugs, such as certain drug classes, insulins, anti-diabetic agents, words I can't say, immunomodulators, immune suppressants, and anti-HIV agents. And the update for that is it accommodates the 2016 data. Non-discrimination clinical appropriateness tool. It analyzes the availability of covered drugs associated with 4 specific conditions. Those conditions are diabetes, rheumatoid arthritis, bipolar disorder, and schizophrenia, as recommended in clinical guidelines to ensure that issuers are offering a sufficient type and number of drugs. And the update for this tool is it accommodates 2016 data. There's a final tool, which is the mental health parity tool. I don't believe this tool has been released yet. So this is a new tool for 2016, and it compares mental health benefits to medical surgical benefits to ensure that all mental health benefits have cost sharing and limitations that are equal to or more generous than comparable medical surgical benefits. So that is a summary of all of the tools. And again, it is highly recommended that you use the tools. Not required, but it will certainly help make your templates cleaner. And it's beneficial for you. You don't have to go in and do a lot of these processes manually. This just talks about the data integrity tool. And this one talks about the data integrity tool functions. And we've kind of talked about these, so I'm not going to spend a lot of time on this. These are the reviews. And you know, the CMS does say you're expected to use the data integrity tool before each submission. Something I want to point out is that you're going to get, you know, there's a lot of notices that get sent after data is submitted, and data integrity notices are different from correction notices, which are generated during the separate QHP certification review. So you may actually get critical data error notices from CMS. And you also could get a notice saying that you have no critical errors, which would probably be a very happy notice to receive. So something else to point out is carriers are expected to use the tools and resolve all data errors prior to data lockdown on August 25th, 2015. And if you don't have those data errors fixed by then, you run the risk of not being certified. So it's very important, excuse me, to get all of the data errors resolved by that time. And the tools will help you do that in a more efficient manner. Next area that I'm going to talk about is plan preview. And so last year, I think some of the carriers on here may remember this. Some of the plans did not display correctly in the plan preview on Healthcare.gov, and this was very close to open enrollment, so it was kind of a stressful time for folks. So this year for plan preview, you're going to be able to go in and test plan preview beginning sometime in May. And so there's also going to be some new scenarios that will require testing. And we will assist with providing some testing scenarios for you and make that process smooth. And the other thing is you're going to want to test the payment links again here. This is a good opportunity to test to be sure that your links are going directly to the payment page of your website and to be sure that it's working correctly. So plan preview opens in May, and you'll be able to start your testing in May. And you have to log in through HIOS, the Health Insurance Oversight System. And remember that you're submitting your templates through SURF, but you do need to have a HIOS ID, and you need to have a login for that. So if you haven't done that already, be sure to get that done. So you'll be able to test the various scenarios in HIOS, and then you'll be able to correct the errors. And you're going to correct the errors. Let's see here. You're going to correct the errors by updating the data templates and resubmitting, or you're going to use the data change request procedure. And after 825, there will be corrections to display errors only. So, but the goal really should be to try to get those resolved even before 825. And if it's a non-data related display errors, you'll submit a ticket to CMS, and I think some folks are familiar with that process. So some of the improvements for plan preview, it's updated to match the 2016 templates, and it's updated to match 2016 plan compare logic. And here is the important thing, because you're going to need to test additional scenarios. There's more dependents and more relationships available. You can enter up to 5 dependents and spouse, domestic partner, and child dependent relationships. That was something I think we had an issue with last year. We couldn't enter some information. And then another thing that I am very happy about is that reason codes for plans which don't appear for particular demographic scenarios. There's going to be reason codes available, which I really like. I think last year we had some questions about why certain plans didn't appear. And you'll be able to view the payment URL. So 2 versions of plan preview will be accessible. You can do the 2016 version to include the updates as we just talked about, and then 2015 plan preview will still be available, so you can still look at your 2015 plan. And then for rating scenarios, you'll have more dependent options. Again, this is what we talked about with creating more scenarios and testing different scenarios in the plan preview. You'll be able to do more testing on that. So the benefit plan display errors have included situations where a discrepancy is identified between a carrier's QHP or SADP data and its state-approved form filings. Then there's a data entry error. So during data correction windows, CMS allows carriers with approval to correct the critical data errors on a case-by-case basis. And when the carrier's error appears on Plan Compare, it confuses or misleads consumers about their rates or benefits. And again, last year it was a bit problematic. We had several carriers who had issues with their plans not displaying the correct amounts, and hopefully this year we can get those all resolved prior to 8/25 so that we're not dealing with that close to open enrollment. So the consumer impact of plan display errors. For changes that carriers request after open enrollment begins, CMS will consider the impact of the change on consumers. And CMS will communicate an initial determination of consumer impact to the carrier with the approval of a change request, including the potential for an informational notice and special enrollment period to return to the marketplace and have the option to select a new QHP. So there are, if the data errors do appear during open enrollment, there are some situations where it can be rectified and adjusted. The Plan ID Crosswalk template. All carriers offering, we've already kind of talked about this, so I'm not going to talk too much about it. But again, you're going to want to be sure that you submit the template in XML form to the email address that's listed here. That's in addition to submitting it in SIR. If you have multi-state plans, we're not talking a lot about that here because that process is a different submission process, and it's based on OPM instructions. If you need some direction on where to get that information, I think we can help you with that, but we're not familiar with that process. So the Plan ID Crosswalk template submission process, error notices. So we talked about these as well. CMS anticipates including crosswalk template errors with the broader correction notices for QHP certification reviews. This applies to the standalone dental plans as well. State authorization of the Plan ID Crosswalk template. The DOI and the exchange will review the template for compliance with Affordable Care Act market reforms such as uniform modification of coverage standards. Carriers will be notified by the DOI and exchange if compliance issues are present, and the exchange will notify CMS when the Plan ID Crosswalk has been approved. And carriers must use the Plan ID Crosswalk review tool prior to submission. Again, that's the tool, that's the new tool that we talked about. Next, I'm going to talk a little bit about SHOP. If there's anyone on here that has additional questions on SHOP, we may have a separate webinar on that as well. So some of the changes for SHOP are that the number of employees will be between 1 and 100, and that's a change from 50 from last year. So, and you must offer coverage to all employees who work 30 hours or greater per week. The minimum participation rate is 75% for Nevada, and that's different than the standard rate. I believe the general rate, it's 70%, but Nevada, it has to be 75%. And there is a special period of time. So employers who enroll in SHOP coverage between November 15 and December 15 can offer SHOP coverage without meeting the percentage requirement. So it is to people's advantage to enroll during that period. And to have SHOP, you have to have an office or employee work site within the SHOP service area. So again, these are the changes for SHOP again. So a very big change, and this is a very good change. Employers offering coverage to SHOP, you can offer dental-only plans, and not you don't have to offer medical. So SADPs, you guys can offer SHOP plans, and people don't have to have a medical plan as well. But the employee has to enroll in a dental plan before dependents can enroll, which is same as the medical coverage. The dependent child-only plans are not available in SHOP. And again, so as a general rule, dependents of a qualified employee will only be able to enroll in the same medical and dental plans in which the qualified employee has enrolled. So those are some changes, and I think they're positive changes for the shop, especially being able to offer dental plans without having to offer medical. Another change is the premiums be based on average enrollee premium amounts, and this is the ability to calculate and display premiums based on the average enrollee, based on the number of enrollees. And you do have to make a decision on whether or not you're going to offer your plans in this way. So as part of the application process, medical and dental issuers will document the decision to accept or not accept premiums based on average enrollee premium amounts. And a new variable has been added to the plans and benefits template that, that allows to capture that information, whether or not the employer has, or the issuer is offering premiums based on average enrollee premium amounts. Online renewals. This slide just talks a little bit about the circumstances that are considered online renewals. Renewal of the shop participation and the coverage that was previously offered, or renewal of the shop participation but not renewing the previous coverage offered. And the election period will begin when rate and plan information becomes available for the quarter in which coverage would end, but not more than 2 months before the date an enrollment must be submitted. Again, this talks a little bit more about the renewal of coverage. If a qualified employee enrolled in a QHP through the shop remains eligible for coverage, the employee will remain in the qualified health plan selected the previous year unless, and these are the ways that the coverage would terminate, the qualified employee terminates coverage in accordance with the standards identified in 155.430. The qualified employee enrolls in another QHP if the option does exist, or that particular plan is no longer available to the qualified employee. So employee choice is now going to be available to all qualified employers in all states. So you'll have for next year, employers can have a choice of 2 different methods of their qualified health plan. They can offer qualified employees a choice of all QHPs at a single level of coverage, or they can offer a single QHP. Employees also have the option to make available all SADPs at a single level of coverage, high or low, or a single SADP. And again, this is a nice change. If you're giving your employee, for SHOP, it gives the employees a little bit more choice. Hence the term employee choice. And the group size, we talked a little bit about this. So for plan year next year, beginning January 1, 2016, a small employer is defined as an employer who employed an average of at least 1, but not more than 100 full-time equivalent employees on business days during the preceding calendar year, and who employ at least 1 employee on the first day of the plan year. And if you're going to go from large to small, you're going to have to provide documentation on the number of employees to CMS. Okay, so the last area that we have are some resources that are available to you during this process. You should have a CMS account manager, and the account manager is supposed to be your primary point of contact for non-technical QHP and SADP issues related to the marketplace. And supposedly they can clarify issuer responsibilities and requirements for participation in the FFM. But don't forget that we are a state-supported state-based marketplace, and so some of our rules are a little bit different than your standard federally facilitated marketplace. They also coordinate resolution of some issues, and again, they have stressed that the account manager handles non-technical questions on the certification process. So last year, I did not hear a lot from the account managers. You know, we didn't have ton of interaction with them, so hopefully you'll have better luck this year if you have some questions. This slide also has some additional resources. This is the CMS website, the general information on the ACA and the application process. Then there's a link here for the specific plan management information. RegTap, if you haven't signed up for the RegTap webinars, they're very good. A lot of the webinars will focus on a specific template, and it's also a good way if you have questions and you're having some trouble getting a hold of CMS. It's a good way to get some questions answered in a pretty quick way because they usually have a Q&A period on those calls. So I would encourage you to register for RegTap and sign up for some of the webinars that are specifically related to plan management. CMS Zone, I think everyone should have an account with Zone at this point, and you probably are aware that there's a group especially for issuers. And so there's a lot of technical information that is stored on that site. And this next slide tells you how to get access to the private issuer community. So you're going to have to get your EIDM registration completed, and then you have to register to get into the private issuer community with CMS. Here are some other information. This is just the ACA exchange and market standards, and then the Code of Federal Regulations. These are all the code sections, basically, and it's probably boring to most people who are not. Well, maybe not. A lot of people on here are compliant, so it's relevant. So this is a link that just gives you quick access to them. I think that's it. So I'm going to take a look at the questions here. I'm going to answer your questions now. We have several. So Margie's question, guaranteed rates are required to have the rates display on Shop Exchange. Did this change for 2016? And this is for SADPs. I'm going to turn this question over to Glenn.
Sure, that was covered by the slide titled Guaranteed versus Estimated Rate. The last bullet point on that slide, shop rates must be guaranteed. So I didn't state that, but it was in the slide. So the flexibility to have estimated rates is for individual standalone dental plans only, as this slide indicates. Shop rates must be guaranteed.
Okay, so Margie, you have another question. Are different copays coinsurance allowed for adults in a family dental plan? Even though utilization for an entire family will be used to develop rates, if adults have different benefits because they don't have the out-of-pocket maximum limitation, the premiums for 21 plus may still be different than the child rate. Is DOI allowing that? I'm going to turn that question over to Glenn from the DOI.
Yeah, that's a discussion that I prefer to have with the pricing actuary for that carrier. Thank you.
Question from Kathleen. Can you tell me if Nevada is using the QHP plans and benefits template from SURF this year, or is there a requirement for a modified version of the template? As far as I know, we're using the SURF template. So, and I know you're off exchange. So as far as I know, that is the right template to use. Elizabeth, I'm going to say your last name wrong, Spratian. On the business rules template side, in the required minimum relationship bullet, what is meant by other relationships? I'm going to turn that one over to Glenn as well.
Well, I wish we knew the answer to that, but this is a kind of a catch-all category, that there are some potential primary dependent relationships that wouldn't necessarily be captured with the other dependent relationships that are specified. So this is just a catch-all that CMS has. So we don't know the answer to that, but this is just to allow some unforeseen households relationships to be captured, so those households can purchase a plan on Healthcare.gov.
Okay, are there any other questions? If so, you can go ahead and type them in the chat. Anyone else have any? Oh, hang on one sec. Okay, Patty, please confirm that service areas and rating areas must always match. I'm going to turn that one over to Glenn as well.
Yeah, thanks for that question. That is an active board decision that they must match. So planned service areas must equal the same. The board decided to align service areas on the exchange with the rating territories established by the Division of Insurance. So the only option that you have for a QHP or standalone dental plan service area is to cover at least one of the rating territories that is defined by the DOI. So that means that you cannot have a Clark County only service area. For Southern Nevada, as an example, you would have to have a planned service area that equals all of Clark County and all of Nye County. So there isn't that flexibility for 2016 based on that board decision.
Okay, great. Kathleen Freund, your question is, would we submit XML of the plans and benefits template into the QHP binder under the template tab in SIR? You don't have to submit that in XML. The XML file is specifically for that plan ID, as far as I know. So that can be, I think you can just submit the Excel version of the, you must submit the Excel version of the plans and benefits template. Kathleen, your next question, is there's also a requirement for a separate network adequacy binder containing all that is listed on the slide. Does that mean that we create a separate network adequacy binder or just put these documents into supporting doc tab in the QHP binder? I'm going to turn that one over to Glenn.
The QHP binder must not contain any network adequacy support. All of the support for QHPs in a separate binder titled Network Adequacy. That's for QHPs. Standalone dental network adequacy, that review is going to be done by the exchange, not the DOI. So the support for network adequacy for dental would be included in the dental certification binder. But again, the certification binder for QHPs must not include any network adequacy support other than the required ECP template that's validated in that particular tab.
Thank you, Glenn. Okay, so G. Harris, the question is, a QHP can combine more than one rating area into a single service area. Is that correct?
Yes, Glenn, that is absolutely correct. So a plan could service the entire state. So that would compose 4 different rating territories or service areas. It's just that what you couldn't do is, let's say, have all of rating territory 1, Southern Nevada, which is Clark and Nye, and then just one of the counties in rating territory 4. So as long as the planned service area is composed of just rating territories as defined by the Division of Insurance, then it's a service area for a QHP that can be certified.
Thank you, Glenn. So Kathleen, your next question, the network adequacy binder, is it needed for off-exchange only issuers? I'm going to let Glenn take that one as well.
No, every carrier, whether they're on or off the exchange, every carrier needs to submit one dedicated network adequacy binder for all its plans in the individual and small group markets. That's medical carriers. So that is a requirement. I'm talking about health benefit plans. I'm not talking about dental. So there's just one dedicated network adequacy binder for all individual and small group plans, whether they're on or off exchange, QHPs or not QHPs. And that process for reviewing those networks are identical whether those plans are sold on the exchange or not.
Awesome. And Kathleen, you're welcome. And are there any other questions? And you know, this is not, you know, the end-all be-all for questions. Please feel free to, you can email any of us, and we will send out some information with our, if we haven't already, we'll send it out with our contact information so you have that. And we're all here to support you guys through this process, so please feel free to reach out if you have questions, problems, concerns. So, you know, you're not in this alone, and hopefully we're going to have a very smooth plan certification year. Anybody else have anything else? Okay. I think we're going to go ahead and end the call a little bit early. Again, apologies for the little bit of a snafu. The presentation will be available on the various websites, and again, we'll send all that information out to you. And thank you for your time. Have a good day.